Good afternoon to everybody, but also good morning and good evening to many of us. It is our pleasure to welcome you to the 14th ITM Alumni Webinar focusing on COVID-19 in Brazil, a regional and local perspective on clinical case management in the early phase of the pandemic. In the ITM Alumni Webinars on COVID-19, ITM alumni share their expertise on a specific dimension of the outbreak in their country. The main aim of this series of webinars is to share experiences, expertise, and good practices within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now explain some practicalities related to the webinar. If you want to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. The chat is being disabled for questions. Questions will be moderated and only a select number of questions can be answered in live, given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. You can, however, use the forum of the alumni platform to start a discussion on your questions left after this webinar. Questions related to technical issues will be dealt with by the ITM technical IT support. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM YouTube channel and alumni platform. Our today's moderator is Dr. Esther van Kleef, Senior Epidemiologist at the Department of Public Health at ITM. Esther holds a PhD in infectious disease epidemiology from the London School of Hygiene and Tropical Medicine. Her research and public health expertise largely concerns understanding the transmission dynamics of pathogens and effectiveness of interventions, with a special interest in antimicrobial resistance and a recent focus on epidemic intelligence and COVID-19. Prior to ITM, she worked in academic and public health roles at the Oxford University, Public Health England, the Dutch National Institute of Public Health and the Environment, and WHO. Esther, the floor is yours.
Thank you, Charlotte. It's my pleasure to introduce to you all Ana Paula Matos Porto. It's a real great honor that she's here and that she's also taking the time to share both her clinical as well as her academic expertise on COVID and beyond. Ana Paula holds an MD and is an infectious disease specialist with a background in infection prevention and control. She works as a COVID-19 researcher at the School of Public Health of Ceará, which is in Fortaleza in Brazil. Moreover, she is also working as a PhD student at the Department of Infectious Disease of the Faculty of Medicine of the University of São Paulo, and has a specific focus in her research on antimicrobial stewardship. All these topics will be part of today's presentation, so it's definitely going to be exciting and interesting. Ana Paula, the floor is yours.
Thank you. And good morning, Brazil. Good afternoon for everybody in Europe. And I'd like to thank Esther and all the organization of ITM for this invitation. And I'm very happy to be here and have this opportunity to share our experience in Brazil and come back after 2 years that I studied at ITM and help with some our data. So I'm going to start. First, short overview of the COVID-19 crisis in Brazil. And since the first case was reported by the end of February, the country became rapidly the epicenter of the disease in Latin America and is currently the third most affected country in the world. And by yesterday, we had confirmed more than 18.7 million cases in Brazil and more than 525,000 deaths in our country. And this death toll is likely to be higher due to underreporting. And the main causes are the deficient surveillance in our country, limited testing, and issues with the reporting of suspected COVID-19 deaths and deaths at home. And after more than 1 year of the beginning of the pandemic, we can assume that Brazil is an example of a largely unmitigated pandemic. And in part because of the marked regional inequalities in the country with different regions, but mainly because of the lack of a national coordination informed by science, the promotion of disinformation, non-compliance with COVID-19 related public health measures, particularly the relaxing for social distancing. And one of the most critical points is the very slow immunization rollout, results in a low vaccine coverage. And by now, we had only 13% of our Brazilian population fully vaccinated. So I would like to talk about, I think everybody agrees that the COVID-19 crisis, it's caused an unprecedented global health crisis with some direct consequence and indirect implications. Some examples of the direct consequence are the increase in the number of hospitalizations, in the number of ICU admissions, many times causing a saturation of ICU beds, and as well as an increased morbidity and increased mortality. But the indirect implications of COVID-19 are not so discussed as the direct implications. And one very important example is the impact of the pandemic on the healthcare-associated infection prevention strategies. The reasons are because the research routinely used to prevent these infections, the AJIs, were redirected to the containment of the pandemic. And another challenging problem that many hospitals faced during the pandemic was the shortage of personal protective equipment that can facilitate the spread of multi-drug resistance organisms. And finally, the increased empirical antibiotic use to treat patients with COVID and associated with the reduced antimicrobial stewardship activities in many hospitals, they may have an effect in the increase of antimicrobial resistance. And all these factors together might affect the AJI rates. So this first study in Brazil, we can illustrate an example of direct consequences of COVID-19 in Brazil. And we studied the factors associated with COVID-19 hospital mortality in a dedicated tertiary hospital in Ceará. And we compared the first and second wave. A short background on COVID-19 preparedness in Ceará, that is one of the earliest and most affected states in Brazil. And the reason is, one of the plausible reasons is because Fortaleza, our state capital, is a busy aviation hub to Europe and North America. And also is the capital in the country with the highest demographic density. And this hospital, Hospital Estadual Leonardo da Vinci, it was rapidly conceived and began operation in the very early phase of the first wave in Ceará as a public hospital. It totally dedicated to assist moderate and severe COVID-19 cases. And most of the beds are located in ICUs. So this study aims to compare the characteristics, clinical outcomes, and factors associated with hospital mortality of COVID-19 patients admitted to this hospital, Leonardo da Vinci, during the first and second wave. And it is in a retrospective, single-center cohort observational study of adult patients. And the inclusion criteria were having a confirmed infection by RT-PCR for SARS-CoV-2 and a definite hospital outcome. That means had been discharged to home or deceased during the hospital stay. And we obtained data from electronic medical records using a standardized web platform named ResCovid that was developed by the School of Public Health in Ceará. And this, to explain the study period, I brought this graph with the number of deaths in green and confirmed cases in orange per day in the state of Ceará. It's important to note that the scale for confirmed case is higher than for deaths. So, but it's visually clear that the second wave in Ceará was much more catastrophic than the first one. And in the bottom, these two graphs illustrate the number of cases and deaths in the first wave of the study population of this hospital. And we can see that we try to capture the patients during the rising of the number of cases in the first wave until we reach the peak and remain in a high plateau. And to try to make a fair comparison with the first wave, in the second wave, we will also capture patients during the rising of the number of cases until we reach the peak and stay in a part of the high plateau. Although the periods are different, the second wave was shorter, but the number of cases was almost the same. In these two flow charts, I can illustrate where we started with almost 1,000 patients in each wave, but we excluded confirmed cases without confirmation. We excluded patients that were transferred to other hospitals. And at the end, we included 657 patients in the first wave and 646 patients in the second wave. And our results are not yet published, but the preliminary results of the first wave will be presented at ECME next Sunday. The first table, it's about the demographics, and it's important to note that the age in the second wave was lower. 6 years, they were 6 years younger than the first wave, the patients. And most of our patients in this hospital, Estadual Leonardo da Vinci, they came from another primary healthcare unit, most 8% of the patients. But in the second wave, we received more patients that came from another hospital. About the clinical characteristics and personal history, it's important to note that there was no difference in between the waves, but 70% of our population had at least one comorbidity. And comparing the waves, obesity was more prevalent in the second wave, and there was a lower frequency of diabetes, coronary disease, and neurological disease. And also we compared the number of comorbidities per patient. And patients in the first wave, in the second wave, we had patients with fewer number of chronic diseases, multiple chronic diseases. In regard to symptoms, the first symptoms we observed in the second wave, less fever and respiratory symptoms. These two tables present the data of clinical presentation at hospital admission. And this vital signs, SOFA and quick SOFA scores, in the second wave, this data suggests that these patients, they presented a lower severity of the disease at the moment of hospital admission. That is corroborated by this other data, that is the use of oxygen therapy at hospital admission. And patients in the second wave, they used less oxygen supplementation. And it's important to highlight here that about 70% of our population, where they were already using oxygen supplementation when they arrived at this hospital. And about 20% had already been intubated in other sites. And we also analyzed the laboratory findings at hospital admission. In the second wave, the patients presented less altered laboratory markers, except for the lymphocyte counts. And regarding pharmacological treatment during all hospital stay, we also analyzed this data. In the second wave, patients used more corticosteroids and anticoagulants. And this can be explained by the new protocols that recommend the use of these drugs earlier for critical patients. And they used more analgesics and anxiolytics, and they used less azithromycin, and there is no use of antimalarials compared to the first wave that we had a lot of use of drugs, off-label therapy. And the second wave, also the patients presented less non-respiratory complications, and most of them with a significant difference. But there was no difference in the need for ICU care. Around almost 70% of our population had been transferred to the ICU. And as we show in the previous slides, with the need of oxygen therapy was lower in the second wave at the moment of hospital admission. During the all hospital stay, they used less oxygen therapy. But, and we categorize the type of respiratory support. They used more nasal cannula and more non-invasive mechanical ventilation, the conventional and the ELMO respiratory support, that is like the helmet in Europe. And they used less mask oxygen and invasive mechanical ventilation. Although there was a decrease in the use of mechanical ventilation, it is still very high. They use around 46% of our entire population. And all the outcomes, time-related, are longer in the second wave, including the duration of invasive mechanical ventilation that was 3 days longer in the second wave. And one of our main finds is that the overall in-hospital mortality decreased from almost 48% in the first wave to 39% in the second wave. But the mortality associated with invasive mechanical ventilation remains the same, very high, around 8-9% of patients died. In this last graph, we show the multivariate analysis of factors associated with hospital mortality in the first and second wave. In the right, you can see the relative risks in the confidence intervals for the first wave in blue and second wave in red for all variables. And we found that in the first wave, older weight was associated with increased mortality. The use of vasoactive drug also was associated with increased mortality only in the second wave. And in both waves, the use of oxygen therapy by nasal cannula was associated with decreased mortality, and by through mask oxygen and invasive mechanical ventilation was associated with increased mortality. So our conclusion of this first study is that in comparison with the first wave, the second wave patients were younger in our hospital. They lived in higher human developed index areas. I didn't emphasize this data in the first table. They had a lower frequency of multiple chronic disease, but higher prevalence of obesity and lower prevalence of diabetes, coronary neurological disease. They presented less fever and respiratory symptoms. And at hospital admission, the signs showed that these patients had lower severity of the disease, including the less need for oxygen supplementation. They used more corticosteroids and anticoagulants, and there was no use of antimalarials. They presented fewer complications during all hospital stay, and they used less invasive mechanical ventilation, but the patients that needed, they used it for longer periods. And there was a lower overall in-hospital mortality, but the mortality associated with invasive mechanical ventilation remained the same. And in the factors associated with the increase in hospital mortality, we found that in the first wave, AIDS and the use of vasoactive drugs were associated with this increase in hospital mortality, and the use of mask oxygen and invasive mechanical ventilation in both ways. Now, let's move on for our next study this study I brought to exemplify the indirect implications of COVID-19 in Brazil. And we evaluated the healthcare associated infections on the ICU in 21 Brazilian hospitals during the COVID-19 pandemic. So it's important to study the implications of COVID-19 on AJI and antimicrobial resistance in Brazil, because our vulnerability to AJI outbreaks as in other low and middle income countries. And this is due to our previous endemicity of AJIs and high rates of antimicrobial resistance before the pandemic. This study with 28 adult ICUs in Brazil that is recently published, they found a high burden of AJIs with an overall prevalence of 31%. And this other report from Anvisa, our national system agents, surveillance agents, they, with the participation of 72% of Brazilian hospitals to evaluate catheter central line associated bloodstream infections, they reported high resistance rates and a prevalence greater than 70% for carbapenem-resistant Acinetobacter and methicillin-resistant coagulase negative Staphylococcus. And it's important to question the role of AJIs as secondary infections and antimicrobial resistance in patients with COVID-19. In this study in Wuhan, in the very early phase of the pandemic, they evaluated the hospitalized adult patients with COVID-19, and half of the non-survivors, they presented a secondary infection. So, this study aims to evaluate the impact of the COVID-19 pandemic on the incidence of central line associated infection and ventilator-associated pneumonia in 21 Brazilian ICUs. It's an ecological study of ICU-admitted patients with suspected and or confirmed COVID-19 cases, and we compared the pandemic period from April through June 2020 with the same period in the previous year. And on the right, there is the map of Brazil and the location of the 21 hospitals from in 6 different states, but most of the hospitals are located in São Paulo. And here are our results. During the pandemic period in red, there were fewer patients admitted to this ICU, 21 ICUs, but the number of patient days remained stable. On the other hand, there was a significant increase in the number of central line days, the number of CLABSI, the number of ventilator days, and the number of VAP. And in the right, we analyzed the CLABSI incidence density per 1,000 central line days, and there was an overall increase during the pandemic. And when we stratified by public and private hospitals, this increase did only reach statistical significance among public hospitals. For VAP incidence density per 1,000 ventilator days, the only increase that was statistically significant was among private hospitals. And also we compared the causative organisms of CLABSI and VAP among these 21 Brazilian hospitals, and we found that during the pandemic, there was a significant increase in the proportion of infections, CLEBs, caused by Candida species and Enterococcus faecalis, and a decrease in the proportion of infections caused by Staphylococcus aureus. But since we had several causative organisms, after adjustment for multiple comparisons, the only significant difference was the increase in the proportion of infections caused by Enterococcus faecalis. For VAP, there was no significant difference in the causative organisms between the two periods. We evaluated specifically the multi-drug resistance organisms causing these two infections, and there was an increase in the proportion of infection of CRE and carbapenem-resistant non-fermenting gram-negative bacilli, MRSA, and VRE. But this increase, there was no significant difference. And finally, we also evaluated antibiotic consumption, calculating the defined daily dose for select antibiotics in 16 of the 21 Brazilian ICUs, and we found a slight increase in the total DDD in the median for ceftriaxone and meropenem, and a decrease in piperacillin, tazobactam, and vancomycin, but this difference was not statistically significant, so there was no difference. In conclusion, during the COVID-19 pandemic in these Brazilian ICUs, we found an increase in CLEBS incidence density, in the proportion of CLEBS caused by Enterococcus faecalis, in the VAP incidence density, but only in private hospitals, but there was no significant difference in the use of selected antibiotics. We evaluate only these four. That is a limitation of our study. So it's important to reinforce the AJI prevention strategies in adult ICUs during the COVID-19 pandemic. And I would like to finish my presentation with some important points to discuss regarding the first study, that the reduced overall in hospital mortality may be explained because we had younger patients. Also, these patients, they had access to improved treatment. And after 1 year of the beginning of the pandemic, we accumulated knowledge and experience with the disease. And we couldn't analyze the impact of vaccination because our second wave in our study, the study population, we are just began the vaccination in Brazil, and it was very slow and only for some priority groups. And you need to study more about the role of new variants. Our second wave, the gamma variant was the most prevalent, and maybe can explain mortality in younger patients. We need to study more of this. And but the most important and critical point of our results is the mortality associated with invasive mechanical ventilation, because it's still very high. And even if we compare it with other studies, there is a Brazilian study where they evaluated more than 250,000 patients from the 5 regions, and they found a very high mortality rate in mortality associated with invasive mechanical ventilation, but it was lower than ours. And so we need to think more about this, if there is some room for improvement, and use more the non-invasive mechanical ventilation, try to use other types of treatment to postpone or avoid the use of invasive mechanical ventilation. And regarding the second study, it's important to question if there was an underreporting of AJI rates, because we know that during the pandemic, all the healthcare workers were overwhelmed, including the people that work with infection prevention and control. And probably this might have affected the monitoring and surveillance of AJIs, and the impact on antimicrobial resistance. Although you didn't find great results, probably because you need longer periods for evaluation, and the antimicrobial use that we didn't find any important difference. But I think there is no doubt that there was an overuse of antibiotics during the pandemic. And some key takeaways of my presentation, based on the Brazilian situation in these two studies, is that first, Brazil is a case example of a largely unmitigated pandemic. And it's important to be aware of the difference in patient characteristics and clinical outcomes during all the course of the pandemic. We already found difference between the first and second wave. It's important to help us to be more prepared if you have to face a third wave. And there is no doubt that we need more research on indirect consequence. I'm not only talking about my field, that is on antimicrobial resistance and healthcare associated infection, but also in other indirect consequences as mental disorders or cancer. And if someone asks me my top 3 priorities for the pandemic containment, I would say vaccine, and vaccine. And finally, I'd like to thank my 2 teams. This is all the people that are worked with me in this project in Ceará. And there are some stakeholders, and also I brought the pictures of people that collect the data, and because they are always in the backstage, but it's important to show them because without them we don't have data. And this is my second team, my team. A great team of infectious disease physicians spread all over Brazil, and we are all connected by the desire to do research, and they worked with me in the project about AJI and antimicrobial resistance. And thank you for everybody in ITM, and Esther that helped me a lot in the preparation of this webinar, and for everybody that is watching. Thank you.
Thank you very much, Ana Paula. That was super clear and very interesting. I see there's one question in the chat. Before we go on to the questions in the Q&A, and I hope more questions will follow, I had also one question for you, which just crossed my mind when you were showing the results on the changes in antimicrobial use, that if you just looked at it univariately or just basically at the numbers, you saw a slight increase in ceftriaxone and a slight reduction in piptats. Is there any, what I'm just curious about, was there in Brazil any potential effect of a disruption in supply chain on antibiotics? Because I know COVID did have that effect in globally in quite some countries.
Yes, we would expect a greater increase, like a significant increase, because we see in hospitals that for these COVID patients that are very severe and needed hospitalization, it's very common to use antibiotic to thinking about they are very critical, and the physicians, they are afraid because the severity of the disease, and then they want to cover with antibiotics. So ceftriaxone with azithromycin is the combination that they use in the early phase of the hospitalization, and then with the advance of the disease, they going increase the spectrum of the antibiotics. So it was surprising because I was expecting a significant increase in these antibiotics, but we didn't find.
No, but and that's where my question came from. Whether you think there might have been a disruption in the supply chain, or were the same amount of
No, I think no. I think it was in the early phase. We didn't in that moment we didn't fight, but now in the over the course of the pandemic in the last year, but we found some problems with the supply of, but more for multi-resistant drugs used for multi-resistant infections like polymyxin. We have some shortage of these antibiotics, but not in this early phase with ceftriaxone and piperacillin tazobactam. I think I remember that we had a shortage of piperacillin tazobactam, but not in this time of our study.
Okay, thank you. I will continue with the questions in the chat. There's one question from Abebe. I'm just going to read it out loud. What possible interventions do you suggest you feel it will work to minimize underreporting? Any trials so far or any suggestions from your experience?
The underreporting of COVID cases or AJI? Can you clarify?
Question. Maybe you can clarify, Abebe, but I think what is meant is COVID.
COVID. Okay, because I talk a little bit about both. First, for COVID, we need improve the capacity, the lab capacity in our country, especially test. In the beginning of the pandemic, the problem was only patients that needed hospitalization that were tested. Then we increased this capacity, but still we need to test more patients. And now I think the concern is about the new variants, and there is a very limited capacity of our labs to the genome sequencing. So this is our biggest problem in this moment. But I would like to talk about also about the AJIs underreporting, because I work as infection control in preventionist in hospital, and I saw that many teams in Brazil were overwhelmed during the pandemic, and we are so worried about problems related to COVID, to the new protocols, everything that I need to take care, and maybe this can have an impact on the monitor of AJIs and on the reporting of AJIs.
Thank you. It was eventually it was COVID. I just need maybe a clarification,
okay.
But it's good to have both clarified. Then a question from Marcelo. I think you covered it partly in your presentation. Did the type of respiratory support change significantly from the first to the second wave in the first study? If so, in what way? Did NIV or CPAP support increase?
Yeah, there was a great difference, because what was available in the first wave was we avoided non-invasive mechanical ventilation, because we are so afraid with the spread of the virus, and control the environment to avoid the contamination of our healthcare workers. Many people were dying in that moment. So you avoid this type of respiratory supports. So we could avoid patients to need invasive mechanical ventilation. And during the first wave, there was the develop more studies about this, and now we had the ELMO in this state, in this hospital in Ceará, that is a type of non-invasive mechanical ventilation. And we are comparing different treatments, so it's not so fair to compare it, because in the second wave we had more research and more knowledge to use different treatments. But also I believe there is a difference in the severity of the disease at the moment that these patients arrived in our hospital. Also, they were younger patients. It's clear there was this difference, and everything is related. I think it's different to separate all these factors.
Thank you, Ana Paula. There's one which goes back to the supply chain question, I think, from Aimgl. I apologize if I pronounced the name wrong. What about the availability of thrombolytics, heparin? Is it used in Brazil?
Yes, we use in Brazil, and there was a difference between the first and second wave. In the second wave, we use it more because the protocols recommend the early use, and also, of course, there are a clear indication, but we noticed that it was an increase. And I'm not sure about if we had shortage of the thrombolate. I'm not sure in anticoagulants, but I think I don't work in intensive care units, so it's not so easy to talk about this for me. Sorry for not to help a lot with this question.
Then we have another question from Hervé, and I think this is $1 million question, and you mentioned it in your discussion. Please, in the second wave, the younger patients were affected. Can we assimilate it to the type of variant responsible for this second wave?
Yes, I think it's impossible not relate to the new variant. I think Manaus, that is a city in Brazil, it's the capital of Amazonas, and it's a city that was faced the biggest catastrophe in Brazil related to COVID, because their second wave its second wave was earlier, and it's totally related to the new variant, the Gamma. And in their analysis, they had younger patients and also mortality in this younger population. So I think in the first wave, we didn't find this. The first wave, we saw in the hospitals patients older and patients with comorbidity. And were these patients that died. But in the second wave, this changed. And I believe that many younger patients use mechanical ventilation. And this is one of the causes, in my opinion, of the longer duration of mechanical ventilation in the second wave, because we had more younger patients. They stayed longer periods of time in the hospital and longer periods using mechanical ventilation. So it's possible not to relate this to the new variants. It's our concern now with the other new variant that you just reported in Brazil, the Delta variant. So we don't know how this variant will be its behavior in our country, but maybe younger patients we don't know yet.
Thank you, Anna. Oh, there's just one question coming in from Robert. Can you maybe comment on transmission dynamics in Brazil? Which communities were most at risk and maybe why?
Yes, there is an interesting finding in my first study that is we analyzed the Human Development Index neighborhoods. It's not so accurate, but it's the place that the neighborhood that patients live in Brazil. And in the first wave, most of patients that were hospitalized and died, they present a very low ADI. But in the second wave, we found an important difference with very high IDI. So, and it's in Brazil, we know that in the populations and communities that they are poor, they need to go out to work. It's impossible to keep the social distancing, and sometimes they don't have access to good and good quality masks. So this population is more exposed. And so the dynamics of transmission in Brazil, they try to to do social distancing, but it's impossible because they need to pick a bus that is crowded. It's impossible. And they need to, because they need to go to their jobs. And so the dynamic of transmission of an infection, we have to consider all these factors, social and economic and factors that differentiate the population in Brazil. Like so it's the virus is the same, but our population, our country is so it's like it's continental dimensions, and so these the facility to spread the virus among the different regions, it's very easy in our country. So because it's difficult to control the borders, the airports, it's too hard, but they try to do. But if other borders, we don't have control. So the transmission is easily transmitted here, but we have a lot of things we could do, and we need, if you had more support of our government to act to prevent the high transmission.
I think that really is a nice kind of lead to the next question from Christopher. Thank you for the great and clear presentation. You said your priority would be vaccine. From your experience, what about those people who have already gotten COVID-19 and survived in Brazil? Are they eligible to take the COVID-19 vaccine, and is it necessary in your opinion? And I think this kind of relates to the discussion we had prior to this session about what do you think is currently the seroprevalence among the Brazilian population. So
yes, I support vaccine for everybody, for all the groups. I know you have to, if you don't have availability of vaccine for all our population, you need to prioritize some groups. It's what we have doing during the pandemic. But the people that had already been infected with the new variants, and also there are many studies about this with the decrease in the levels of the antibodies and other types of immunity. So they need to be vaccinated. Manaus was a very, very clear example of this, that the herd immunity didn't work for COVID. They analyzed that more than 70% of the population had already been infected in the city. So we would expect that they didn't live a tragedy that they lived in the end of the last year. So everybody needs to be vaccinated. It's only except people that there is a clear contraindication, but everybody needs, even if you had already been infected.
Just from my side, then a follow-up question. So with such high levels of seroprevalence in the city as you report, is it in particular groups that you expect basically transmission to be higher? Like, is it certain social demographics that are important and which might facilitate transmission?
Yes, I think now our concern is regarding the younger population, because they are not vaccinated yet in our country, and they are the people that go out, they go to their jobs. Many times they are healthy, they don't have any comorbidities, so they are not priority groups for being vaccinated. So if you don't run this vaccination very fast in Brazil, these people will be exposed, these people. And so I think it will be our big concern in the next months. And also children, that I think will be in the bottom of the priority groups to be vaccinated, children.
Yeah, that's been a bit of a debate in the Netherlands, indeed, about children. So no, currently it's being advised, but then there's the population who has different opinions in some groups. But that brings us to the next question. Actually, I can't read the first name, but from Mr. or Mrs. Misra, and that's just a very short one. That's whether vaccine hesitancy is an issue in Brazil.
Yes, I think it is. In all the world is we have many people that are against vaccine, but at least they are the minority. And most of people still believe in vaccine, especially in Brazil, because we have a history, a very, very good history about vaccination in our country. So, but as I always say that information is so important, but internet also sometimes is not, there are the disadvantages. And so everything that we see in other countries, like in the US, in many that I think it's more these groups against vaccines. They are stronger, if I can say it like this, in other countries than in Brazil. But it's like an inspiration for some people that don't believe in. It's also connected and related to political issues. So these ideologies, and it's not something based on science, but more based on their political choice. So, but we hope that we, with our excellent researchers and specialists in Brazil, people that study a lot about vaccine, we will not have these problems here.
And can you then also specify, because that's another question from Hervé, what kind of vaccine is used in Brazil, and what is the opinion of your people for vaccine? Well, you just mentioned that, and whether they come for vaccinations. I think you kind of touched upon that, but what type of vaccine is currently available in Brazil?
Yes, we have many times now of vaccine in Brazil. The CoronaVac was a Chinese vaccine in partnership with Brazil. It was the first one, inactivated virus, and we had also the Oxford vaccine, the AstraZeneca, and we have the Pfizer vaccines. Now we just received the Janssen vaccine. So we have all the different types of vaccine: inactivated virus, the RNA vaccines, the vector vaccine. We have all these types of vaccines. But it is still not enough to vaccinate our entire population. But there is a slow increase, but we are advancing in our vaccination rates.
Because I think you said in your presentation the current vaccination rate is around 10% or even lower.
13%, yes. 2 days ago, I looked for this data. There was there was an increase yesterday because sometimes there is a delay in the reporting of the data, but till 2 days ago was 13%. That's still low if you think in our country. The number of doses is very, very high in the number of doses, but our population is more than 200 million of people in our country. So it's to 10% of our 10% of vaccination is like 20 million of doses. That is a lot of doses, but it's not the same. I'm talking about fully vaccinated with 2 doses. Most of our vaccines, they need 2 doses, except the Janssen vaccine that just arrived. It's not a big amount of this vaccine yet in Brazil.
We continue on the vaccination. I think for Sinovac, you were mentioning, right, that the Chinese vaccine has also, or a Chinese vaccine has also been available. Yeah. But Sinovac, I think we've heard, has also had its issues and about its efficacy. So one question is, do you plan for a booster or additional different vaccines for those already receiving Sinopharm/Sinovac?
I think they are still studying here. Probably will need a booster, but it's not our priority in this moment. And if this booster will be with a different vaccine, we don't know yet, but there are people studying this. I don't study vaccine. I know as the same that most of people, like the other ID physicians, study. So I think the priority now is vaccinate people that didn't have any dose, get any dose, not to worry now in this moment with a booster of vaccines. But the efficacy of CoronaVac, the Chinese, that now is also produced here, it's very high. It's very high. There are many data showing that the decrease in the number of cases after this vaccine, and also in the number of severe cases and deaths was very important. So I believe in all the vaccine that we have available in Brazil, and I don't choose any. I don't need to choose any among these vaccines available here.
So we're reaching nearly the end of the seminar. We have 3 minutes left, so I'll just leave it with one other question from Abebe. This must be your area of expertise. Have you tried to use Vermectin, Vermectin? If so, have you observed any improvement with patients' health?
What? Ivermectin?
Mm-hmm.
Yes. They used it a lot in the first wave because we didn't know what to do in that moment, especially in the early phase. And so everything that there was a paper that say, oh, this is good. People are so desperate that they try it. But now we are not used ivermectin anymore since the last year. There are some people, sometimes patients, they want to use, they buy these drugs in the pharmacies, but it's not something that is recommended. And I don't have experiences with patients. I work specifically with infection control. And so my experience is more learned when I study the research than with patients. I don't see patients.
Oh, great. I think that brings us to the end. I'm going to hand over the floor to Charlotte for some final words. Thank you very much, Ana Paula. It was great.
Thank you, Esther.
Thank you, Anna, for presenting and sharing your expertise and also your research insights on the COVID-19 outbreak in Brazil. Also, thank you very much, Esther, for the interactive and enriching moderation of the webinar. I would also like to thank Dylan and Tim for their technical support and assistance. Of course, also thank you to all participants from around the globe for attending this webinar. We will now go into a summer break, and we will be back in September for the 15th alumni webinar. Also, thank you in advance for completing the short survey, which will be displayed shortly after. And in the meantime, most importantly, stay safe and healthy. And looking forward to see you again in September. Thank you. Thank you to all.
Thank you.
Bye.
Bye-bye.